So I just wanted to show this example of the effect of this miracle drug for treatment of cystic fibrosis, Trikafta, which helps mobilize the defective receptor protein and get it to the cell surface and make these people a whole lot better. So this is a radiograph on this cystic fibrosis patient in 2019, middle of 2019, and Trikafta became available in November of 2019. It was put on after that. So this is what his radiograph looked like in the bad old days, with lots of mucus plugging, bronchial wall thickening in upper lungs. And now his current radiograph is shown here on the right with dramatic clearing. I think if you didn't have the history that this was a cystic fibrosis patient, you might overlook these bronchial wall shadows, which are there, but much less conspicuous than before. So dramatic improvement. I don't have an old CT at the time when he had his florid disease, but this is his current CT, and you can see that he does have bronchiectasis, mild bronchial wall thickening, and a few mucus plugs, things like this. But this is dramatic clearing over this time. So the effect of Trikafta, it's very dramatic, and a lot of people who were going to require transplant actually have been taken off the transplant list. And there are some patients, according to the cystic fibrosis physician I was talking to yesterday, who are angry because they went ahead and got lung transplant. Then the drug became available, and they felt that if they'd known about that, they wouldn't have undergone the transplant, and they might be spared the consequences of lung transplant, which is not always a walk in the park. Okay, so effective Trikafta, really dramatic.
David, so in patients that are younger, say that don't have all the bronchiectasis yet, does it prevent them from developing it because it keeps their airways functioning?
I think it does, but you know, the drug's only been available about 2.5 years, okay. So I don't know whether long-term studies have been there, but these people are vastly better, and it improves their gut function. So it's not clear that it improves their pancreatic function, but weight gain is one of the consequences of being put on this drug, because the gut mucus, I guess, is more favorable. The microbiome in their gut probably changes too, and they are able to absorb calories better. So weight gain is often one of the consequences of being put on this drug. But when they were doing blinded trials, the dramatic effect of the drug sort of unblinded. The patients could tell that they were on the drug, and the physicians could see it too, because they got so much better even during the blinded phases of the efficacy trials.
Very
okay.
All right.
Yeah, and the sinus disease gets somewhat better, but evidently there's a lot of the structural abnormalities in the sinuses mean that the sinus improvement is less dramatic than it is in the lungs. So I think there are more fixed changes that can't be eradicated as easily in the sinus territory. Okay, last week I showed a case of a inflammatory nerve disease that caused swelling of nerves. And when I showed it to Sudhakar, he checked out this case of neurofibromatosis. So this person has plexiform neurofibromatosis, has this dramatic mediastinal widening, has the apical neurofibromas that were apparent in that case I showed last week of the inflammatory nerve swelling, and then has paraspinal component going all the way down. So this is the only chest radiograph I have on this person. So lots of nerve disease here, and it's really everywhere. This is what CT looks like in this person with dramatic axillary. So one of the things that impressed me on that case last week was how much axillary stuff there was, but this is probably 20 times more. So dramatic axillary nerve enlargement here from this plexiform neurofibromatosis. Goes all the way up in the neck. So all of this bulky stuff up in the neck, and then throughout the mediastinum and paraspinal location, and into the abdomen as well. Now, the one thing I didn't see in a quick scan through all these CT scans are skin lesions. So sometimes you'll see neurofibromas in the skin. I don't see them in this patient just on a quick pass through the CT scan. But dramatic plexiform neurofibromatosis. I think there was intracranial disease as well.
Any
And
or any lung findings?
the thing that impressed Sudhakar, just 1 second, is the involvement of the phrenic nerve, which Travis pointed out in the case I showed last week of the nerve swelling, is swollen nerves. And so for Sudhakar, who likes to, has very good imagination for coming to names with things, he thought this reminded him of the cartoon character Shrek, who has little ears, like little knobs, affixed to the side of his face. And you can see the course of the phrenic nerve very nicely here as it flows out onto the diaphragm here. And on the right, the phrenic nerve is closely associated with the IVC, as you see nicely here. And then here you can see it flowing out onto the surface of the diaphragm here. So it goes down on the top of the diaphragm and it goes through the diaphragm and comes on the bottom surface as well. But you can see the phrenic nerve. So this should appeal to the phrenic nerds in the group. Okay, Jeff, what were we going to say? I'm sorry, I
I was going to ask
interrupted.
if there were any lung findings like cysts or cystic-like spaces.
Okay. As we've scrolled through this, I didn't see anything. So it's said to be a cause of basal lung fibrosis, although I've yet to see a case. This is just indentation atelectasis, and an atelectasis down here, and I didn't see any cysts. Okay, those are the cases I wanted to show.
Very cool. All right, Peter or Travis?
I got a few cookies, Jeff, also.
All right, there you go.
This was a case that some of my colleagues read, and then we added on our cardiac tumor board. But I'll show it. So here's the CT scan, and you can see this impressive, kind of angry-looking or infiltrative-looking disease in the RV wall. Let me window and level it. It's encasing the pulmonary, or the coronary, the RCA there. Then there's clot or tumor thrombus. So you actually see the soft tissues kind of growing into the pulmonary valve there through the RVOT. So this patient actually has lymphoma, but what's interesting is if you look at let's see the original disease, it looks a lot more impressive. So you have all this tumor that's infiltrated into the heart. A lot of this is, well, some of it is superimposed thrombus, giant pericardial effusion, and then lymphoma involving the walls of the myocardium there. So there's just kind of a impressive post-treatment changes here with improvement, but some of it is just kind of burned out quiescent disease. The patient's doing pretty well now. They do have SVC syndrome symptoms like swelling. You can see the SVCs all is essentially occluded here. This is probably just like a lot of scarring and fibrous tissue. The surgeon wants to go in and try to open up this SVC, and potentially while he's in there, he wants to take this out. Oh, there's no uptake here. So I thought it was just kind of interesting. If you only look at the current scan, you would think this is actually a infiltrated disease, but this is actually quiescent post-treatment changes.
That's impressive.
In lymphoma. So another good reminder how important priors are. Okay, this one is my Art Stillman showed me this one. I thought it was a good example. I think we've showed these before. Anyway, it's for an anomalous vessel right here. It's a vein, and you can see it communicating with the with the left subclavian, and it comes down kind of where you would expect a left SVC, persistent left SVC, but it communicates with the pulmonary vein. So this is a levoatrial cardinal vein communicating with the pulmonary artery on the left side, pulmonary vein on the left side, and it actually has a bridging vein as well here underneath the arch, which goes into the SVC. So
is there an anterior one too, or is it just the retroaortic brachiocephalic vein? You've got a double variant here.
yeah,
That's really cool.
yeah. So the thought is that these are persistent. This is basically persistence of the pulmonary venous. So this capillary network here persists in patients that have congenital LV or left ventricular obstruction. So it gives another outlet for the pulmonary venous system to flow into the systemic veins if the LV outflow tract is obstructed congenitally. That's the thought of why this persistence, these veins persist here, is a communication between the systemic veins and the pulmonary venous system. So it's essentially a right to left or left to right shunt.
But was there left ventricular outflow obstruction in this
Yeah,
person?
I don't think so in this patient. I don't know. I didn't look through the history. I don't think that this. I mean, just looking at the image, it just looks like a very normal heart. And here's another. Is a prior study with a different phase with the contrast, and you can actually. It's kind of nice. You can see the communicate. You can see the kind of the mixing here. Yeah, I don't think this. I don't know if this, I don't think this patient had any congenital cardiac, but I saw this. There was an article in AJR which I could send along on. There's a PE here as well on levoatrial cardinal veins, and then they talked about the embryology of them.
But then it looks as if there's a blob down near the descending aorta. If you go down,
Yeah.
what is that? What is that blob there? Is that an abnormal pulmonary vein? It looks kind of bulbous. Track that.
This right there.
Yeah.
Yeah, I don't know. Maybe they had yeah. It looks. I don't know if it looks bulk, but maybe there's a little bit of stenosis here at the
Yeah.
They had an ablation or something. I have to check. Sorry, I don't have the full details on this case.
Or maybe that's another congenital.
Maybe this is some congenital anomaly.
Yeah.
But yeah, it does look like it's a little dilated here. The ostium of the vein is smaller. It has a kind of a neck as opposed to this side. I don't know if that's related. Yeah. And then we'll show one more, which is kind of a nice case. It's for my colleague Stefan Tigas. Nice. I think it's a nice case for trainees. Trauma scan. This is the presenting chest radiograph. Some rib fractures here. Kind of maybe I'll make a case for a widened mediastinum. And here's the CT presentation. You can see a pneumothorax. And I'll show a follow-up and we'll get back to this one. So that was a presentation. And chest radiograph 1 hour later, they put in a pigtail catheter there. And then 2 days later, looks like a large pneumothorax, but looks like actually there's bowel haustra here, bowel markings. So let's take a look at the CT. So you can clearly see that there's large bowel herniated up into the entire thorax. So this is a delayed herniation of bowel through a diaphragmatic defect. And if you look at the CT presentation, you can see the defect right there in the diaphragm. So it took a few days, but they ended up with a large herniation. At this point, you can just see a little bit of mesenteric fat has just herniated, and it obviously got much worse.
That's subtle.
Yeah. Yeah, but anytime there's rib fractures in this region, that's one thing to look for is continuity of the diaphragm. There's a rib fracture right there.
That's a great one.
That's it, guys.
All right, thanks, Peter.
Yep.
All right. Travis, you got any cases?
Yeah.
All right.
Howard still not on here?
No, usually he texts me. I didn't hear from him. I don't know if he's off this week or something.
One of them is a Howard special, just partly, but start with this one. And working our way backwards on this case, this is an older male who presented, and he was having worsening respiratory distress, and as you can see, the right middle and lower lobes are collapsed. And looking at the airways, he's a little rotated perhaps, and it's a portable view. He's, some of this is just volume loss and rightward tracheal shift or mediastinal rotation from the volume loss. But there's this peculiar thing right here that doesn't really correspond to a large osteophyte. And they actually did two images at the same time. I think this one's even more oblique and shows it looks like there's something in his trachea. And maybe I can convince you that it's more than just soft tissue in some areas. This is the CT, and this was all done at the outside hospital. And you can see, in fact, that there is a mass in the trachea, and it's involving the cartilaginous portion of the trachea, as you can see. And it's very dense, and we might think ossification, but the fact that it's arising from the cartilaginous rings, the most likely thing that this is calcified and that it's a chondrosarcoma, which is what it turned out to be. They did a biopsy of it. So they got chondroid matrix, and this is an indeterminate grade of this lesion. They weren't able to excise this, and it involves too many cartilaginous rings. It's pretty close to the carina, especially when you look here. There's probably a little bit of soft tissue creeping down here right to the carina. So given his age and everything else, they're going to try and debulk this thing, but not do surgery. And I think this was all just mucus that had plugged his right middle and lower lobes on this CT. But what makes this particularly interesting, I think the trachea is admittedly a blind spot for a lot of people if you don't actively look at it. This was a CT done outside months ago, also a PE study, and I think the PE study was to the detriment of this patient in this case, because right there is that lesion. But man, if you don't window properly, that I can see why somebody would overlook that. The combination of it being in the trachea, that's a blind spot, and all of that streak from the column of contrast. But probably not too aggressive, since it was fairly similar size months ago. And at that time, he actually didn't have any sort of airway compromise or reduction clearance of secretions distally. But you can see greater than probably close to 75% at this point. So tracheal chondrosarcoma arising from the cartilaginous portion.
Seems like he was short of breath because that was a lot of respiratory motion on the.
Yeah, that's a good point too, right? And it's probably an older scanner too, but you're exactly right. Okay, here's the eye test. This was also from the outside a couple of years ago, so I have no idea if this was interpreted or correctly or not. But I'll let you look for a moment.
Looks like there's
This patient.
double bump
Yeah,
in the aortic
for it.
arch or something.
Yeah, exactly. Good. And right, and we sometimes you think of like a figure 3. There's no rib notching here. There's nothing else to suggest there would be collateral vessels. And the arch itself is fairly distinct. And on the lateral, I think it's right up here. The arch is very distinct. So anyway, this patient came back in, presented with more acute symptoms, and this was what they looked like. So this was 2 years later when they came to us. And you could see that part of this is part of this is left upper lobe, as you'll see. But this is a 58-year-old patient. And the anterior mediastinal component is interesting because you have areas of fluid attenuation, plus you have macroscopic fat. And there's some thickness to the wall, and then this was at surgery densely adherent to the adjacent lung. And also there's a small little reactive pleural effusion. So this did turn out to be a mature cystic teratoma. When they excised this, they had to remove a portion of the left upper lobe that was inflamed and densely adherent. And this patient actually ended up sacrificing their phrenic nerve as well as a result of that. But you can see the lung improved afterwards. So I don't know, it didn't rupture, they said, but I wonder if it got infected. They didn't really comment on it in the path, but something happened that caused the adjacent inflammation to the lung. Because it wasn't just compromising the left upper lobe airway. Have you guys seen cystic teratomas that get complicated by infection or hemorrhage or something else to cause inflammation?
We had one here in a young guy that parasitized some vessels from the middle lobe, and they had to take a chunk of the middle lobe out with it too. And I wonder if you get like maybe thyroidal tissue or something in it that's hypervascular, or renal tissue or something, maybe it recruits a bunch of big vessels and that contributes to it. But yeah, I don't think it was infected because they're usually encapsulated, as you said. So
yeah, so I thought that was a cool one. And then a coronary case here, just because this is a pretty unusual variant. This was a patient who's, again, middle-aged, has had intermittent anginal symptoms and underwent coronary CTA after they had undergone a cath. You can see there's a little less than 50% stenosis in the LAD, mixed calcified and non-calcified plaque. But this was prompted by the coronary anomaly that they found, and they wanted further evaluation. You can see there's an anomalous left coronary artery arising from the right cusp. Doesn't have an intramural segment because it's not slit-like, and it's not an intraarterial. It dives into the muscle here. So this is a transeptal or intraconal, a couple of other, there's other terms for it as well. But curious, your experience at your institutions. I think historically, it used to be this was considered, for lack of a better term, one of the quote benign variants, and that not surgical, like an intraarterial left. But I can tell you at UCSF, we had a few of these that were repaired, and there have been some case reports associated with symptoms, and questions of whether it causes sudden cardiac death. So this patient's being evaluated for surgery. I don't know. I know at WashU, talking to one of my colleagues there, they don't repair these, but the stress test would be the next step, I think, but they may go straight to surgery here. Also, if you guys never look at CT Surgerynet, ctsnet.org, it's a great resource. This is actually a video. You have to go to YouTube to see the video, but they show unroofing the whole surgery in a 12-year-old. And this actually discusses some of their rationale with some case reports of sudden cardiac death in these patients. But this, you can learn a lot about CT surgery here, and they have tons of good videos, and I guess they have podcasts, which I've never actually looked at. But back to the question, anybody want to comment on their experience with treatment of these?
I don't think I've seen one. I'll have to, if Prashant gets back before we finish, I'll ask him and see what he says. But
yeah, and I guess let me NPR this really quick, because yeah, one of the keys is it dips down into the myocardium and has more of this like hockey stick configuration rather than coming straight across, as you would see with an intraarterial. It dips down into that portion of the septum and then comes back up.
I think they published a hammock sign on this one in one of the, I think it was a JTR.
Yeah.
Hammock sign, right? But yeah.
That's right. Stefan told me about I remember Stefan using that 10 years ago, that term. So here you can see that kind of hammock or the hockey stick just dipping
Yeah.
down into there. So
Yeah, I'm not sure about the management, but I do know that they've been termed as benign. I'm
yeah,
not sure what we do with them here.
I mean, I think with,
never
go ahead.
Yeah, that's it.
I was gonna say, I think with the exception of the retroaortic and the prepulmonic, you know, it's just, there's so much uncertainty with these, and I think it's, rather than being dogmatic, they're often managed on a case-by-case basis. So I refrain from the benign versus malignant terminology in these anymore. All right, well, this is a crazy case to finish up on, and this is one that could occupy the entire hour on its own, I think, or at least a full lecture. This is a lady who, 48, presented with just what was described at the time as just like, quote, horrible fatigue. And she underwent a CT, and as you can see, she has cysts. She has a cystic lung disease, and there are a few cysts, and this is an older study with thicker slices. There's a few nodules here. And so they actually went down the cystic lung disease workup, and this is correctly suggested could be LIP. The patient was found to have a combo, like, or an overlap of Sjogren's and lupus. But even on this image here, you can see on the lung windows, when you look at soft tissue windows, coronaries look way too big, and you'll see, you know, the right coronary, there's just tons of motion here, but you know, the left coronary, you never really see an origin for it. And this was, I don't think, detected at the time, but because it was a couple years later when workup continued, and she ended up getting this study, or this coronary CTA, and you can see that she does in fact have anomalous left coronary artery from the pulmonary artery, or Al kappa. I think the clue to one of these, obviously either an anomaly of origin or an anomaly of termination, would be that there's massive dilation. So you've got markedly increased flow. I wish I had the cath for this because it's quite impressive. The flow going from the right coronary through all of these massively dilated collaterals, and then retrograde filling the LAD into the pulmonary artery, obviously going downstream in terms of pressure. And so this creates a steal phenomenon, and you know, can contribute to chronic ischemia in these patients. So they repaired that, reimplanted her coronary, but her, and I'll show that to you. You can see it's just been reanastomosed here. But her lung disease has progressed, and now she has areas where you can clearly see little higher attenuation foci of calcification, or in this case, ossification, in a few of these. And she does have a staple line, and I'll show you that in a moment. I think like right here. But her cystic lung disease is worsened, and she's got these areas of soft tissue as well. So we have a nice long path report for this. And as we've talked about many times, that oftentimes with LIP, you know, you see amyloid. And in this case, this patient had this whole host of things. So they actually had amyloid light chain deposition in here, and as well as lymphocytic interstitial pneumonia. There's a whole long description talking about this. She'd actually had a prior lung resection. I don't have those images, but she had atypical lymphoid tissue and Hodgkin lymphoma in the lung. So I think this is one of the ones where we actually get histologic confirmation that a lot of the times these diseases do contain amyloid, and that's why I think we always treat this along a spectrum, the LIP, amyloid, light chain, you know. And I'm not exactly sure, you know, the difference between a lot of these, other than just beta pleated sheets and other types of protein. But as you can see here, it was interesting just to know. And they did clonality studies on this one, and were negative. So Al kappa plus Sjogren's plus LIP/amyloid/light chain.
That's crazy. And how old was she at the time that Al kappa presented?
In her 40s.
Wow, that's
late 40s. Now, I showed a case, a famous case from San Francisco of, it was a marathoner that was diagnosed with Al-Kappa as an adult. And they had run marathons. And in that case, though, there was more narrowing at the ostium of the left main. And so I suspect it had increased the pressure gradient, so reduced the flow. Here, goes in at a right angle, but I don't see any real resistance to flow.
Yeah, it looks wide open.
So,
Cool.
yeah.
That's really cool. And the path on the cystic stuff and nodular stuff is cool.
All right.
Great, thank you. All right, I've got just 2 cases. Let me see here. Okay, so let's see here. So this is just a case that came in. This guy has a tracheostomy in and was using a. He's got this funny little metal thing here. If you look at it, it's kind of wound braided wire, and this was a pipe cleaner. You know, like you use in crafting that no one actually cleans pipes with, I guess. But he was apparently cleaning his trach out. I didn't know they would do this or supposed to do this, and apparently lost control of this thing. I'm not sure how, because given how long it is in the acute right angle, but nevertheless showed up with a pipe cleaner in there. They were luckily able to just go in with a little scope and grab it and pull it right out through his, and then give him a new trach cannula. But add this to your list of foreign bodies. But I'm sure David has a good joke about windpipes and pipe cleaners and stuff, but not for that purpose. Here it is on the lateral, just showing where it is there. So that was just one of these cute little findings. This is a kind of another fun case. So this is another eye test, not so subtle on the lateral, but on the frontal view, this you can see that there's, if you look, you got descending aorta, looks fine, some old trauma. But if you look in the upper mediastinum here, it looks a little, there's a funny little contour here, but you can imagine you'd write it off to a tortuous vessel or something like that. But the lateral is a little bit better, but this is a great example of looking in Rader's triangle or the retrotracheal space, and you can see indeed there's a mass up here, and it's got mass effect on the trachea. So this patient underwent a bunch of CT scans. So here's a chest CT, and you can see there's this mass sort of above in the lower neck here, somewhere behind the trachea and between the spine. It's got some central low attenuation, some contrast artifact, but it extends behind the esophageal lumen into the upper mediastinum, and then you see the normal looking esophagus. So unclear what's arising from, but could be esophageal. It seems to be midline, doesn't look like lymphadenopathy. But he had a neck CT, and this was done on the outside, but a lot of places do either a dual injection technique or a different slight timing, and you can see we got much better contrast enhancement of the mass, where it looks a lot more hypervascular and necrotic. And I would wonder about this maybe being a paraganglioma or something, and one of the like the vagus or some nerve running down that way. So they went in and did a combined thoracotomy on the right, and then a cervical incision, so thoracic surgery and ENT took this out. Anybody want to take a stab at what this ended up being?
I saw the title of your
Okay.
thing.
Yeah,
I think I've never.
It's a
This is
solitary
crazy. I mean, I would have.
tumor.
Yeah, I would have said like leiomyosarcoma.
Right. I've just not seen. Yeah, I mean, I've seen one arise in the mediastinum. I've seen them arise in the lung. I've not seen any enhanced this much. Usually they're, and also with this much necrosis. So this was considered like intermediate grade based on mitoses, but I've still yet to see one of these recur. But they got clean margins, and they're usually well encapsulated. But they don't always occur in the pleural. And there was a paper, I want to say it was in Radiographics several years back, that talked about solitary fibrous tumors all over the body. But I know we've shown a couple here in the mediastinum, and even I think 1 or 2 in the lung. But some kind of big mass. Always think sarcoma, but yeah, this is a fibrous tumor. All right, and then
I know that like what used to be called, well, maybe they're still called, but hemangiopericytomas in the brain are similar histologically to solitary fibrous tumors. What's going on laterally there by the left rib? Was there anything, or is that just
old trauma?
okay?
Yeah. And then this case is kind of cool. I forgot to grab this third one. So radiograph here, very abnormal. Looks like there's maybe a fibrotic lung disease, but clearly not normal vasculature. And you look on the lateral, volumes look pretty decent, but there's some thickening of the fissures and what looks like a bunch of tiny nodules or something. So this is kind of a little bit of a crazy example of this, but if we look carefully, you can see there's a bunch of tiny little nodules, and you'll see that they're kind of marching along the septa. So looks very good for perilymphatic nodules. So diffuse, but what's kind of interesting in this case is the amount of septal thickening. And so you can imagine perilymphatic nodules like this, you typically think of sarcoid. So this is the so-called miliary sarcoid, but they're not random miliary nodules. They are truly perilymphatic. But I was just taken by how much septal thickening there is. If we look at the lung soft tissues, you can see there are some mediastinal and hilar nodes. They're not massive, but the typical potato nodes of sarcoid. But I don't get the sense there's any compression of the pulmonary veins. So I think this is true septal thickening from granulomatous involvement and not venous compression. But also this is very diffuse distribution. It's not it's not upper lobe predominant, although the septal thickening is more basal predominant. But sort of a miliary sarcoid that's consists of perilymphatic nodules. So.
Jeff, that lymphadenopathy was visible on the lateral view below the left main bronchus.
Yeah, infrahilar window filled in there, and
right, and you obscured the back wall of the bronchus intermedius, the PWBI wall.
Yes.
So I'd like to ask a sarcoid question before you go on.
Okay.
We had a case of a subtle right upper lobe abnormality that I thought was going to be something like MAC, some airways disease. I often have a problem distinguishing sarcoid from airways disease. The person got a CT scan and there was a lot of lymphadenopathy that was not visible on the chest radiograph, and the peribronchial distribution of small lung nodules. So it's classic sarcoid look in the lung and in the mediastinal and hilar lymphadenopathy. But this person had quite a bit of axillary lymphadenopathy too, and upper abdominal lymphadenopathy. So, and a big spleen. So I start to worry about things like CLL with the axillary lymphadenopathy and a big spleen. And I was trying to, I wonder if you guys have ever seen cases of lymphoma or CLL associated with sarcoid. Somebody who has manifestations of both. Is that?
There,
yes.
Pass.
There is a, I forget what they call it, but patients with sarcoid, and correct me if I'm wrong, Travis, but I believe they have a slightly higher risk of lymphoma. There's some relationship.
Well, Howard showed us a paper on this, the sarcoid lymphoma syndrome.
Right.
And there's some relationship.
Yeah, but given how much sarcoid I see, I suspect it's pretty common. But yeah, I always get bothered in sarcoid cases when I see funny nodes. But I've seen cases with internal mammary nodes, cardiophrenic nodes, retroperitoneal nodes, axillary nodes. So I think in those cases, I would encourage someone to sample the atypical nodes just to be sure. I think your point of CLL is a big one, given the big spleen, and the sort of the ones that don't drain the lung are the ones that worry me. But we know they get.
Yeah, I've never thought about CLL, but I totally agree.
Because even though it's a leukemia, it sort of acts like a lymphoma from an imaging standpoint. And
yeah. And plus, David, was the patient symptomatic?
What?
Did the patient have symptoms that might persuade or like steer them more towards the lymphoma?
I think the person came in with a cough. That's what.
Yeah, well, yeah, that's not.
But if it were I'll go back and look at his history. It's just came up this week, so I haven't really had a chance to investigate. No. But we threw in to the report our concerns that there was something more than sarcoid. Yeah. So I'll try to retrieve Howard's paper on sarcoid lymphoma syndrome. But that's a great suggestion. Thanks. I love this conference, guys.
Yeah. All right. Well, that is all I have. So we will wrap it up here, guys. But thank you, and have a good rest.
And David, one more comment on the sarcoid lymphoma syndrome. I'm not sure. I think it goes both ways. Like some patients with lymphoma may get a sarcoid-like reaction, but then I know there's also literature discussing like the if there's an increased incidence of lymphoma in sarcoid patients. And I don't know, like Jeff said, you know, that we see sarcoid so often, those patients are bound to get lymphoma, some of them.
Right. Okay.
All right.
Thanks, everyone.
Yep. Have a good rest of your week.
Thanks.
Bye-bye.